All right. Welcome, everybody, and thanks for joining our physician panel today. My name is Kimberly Doris. I'm the Executive Director of the Graves' Disease and Thyroid Foundation. I'm going to keep the introductions really short so we can hopefully take the whole hour to answer as many of your questions as we can. Dr. Lacey Echalier is a local ophthalmologist working with Fante Eye Clinic. Dr. Alan Ho is with Cedars-Sinai Medical Center in Los Angeles. And Dr. Trevor Angell is an endocrinologist with University of Southern California Keck School of Medicine in Los Angeles. So what we'll do today is we took questions ahead of time from those who registered. And so we're going to work through all of those, and then we'll save some time at the end to take audience questions. And this is a hybrid event. So we've got some people here in person, and then we've got people watching this as a webinar. So we'll try to make sure we get everybody's questions taken care of. If we do not answer, or if we're not able to answer your questions, if you're here in person, our information is on the table back there. Please reach out to us and we'll try to get an answer for you. If you're virtual, you will see our email and our website in the chat. And again, reach out to us and we'll try to get an answer for you. We're a patient organization and we'll never give medical advice, but we can offer general information and hook you up with the right resources. So with that, we will jump right into questions. So first of all, for Dr. Angell, how do you find an endocrinologist that's well-versed in Graves' disease or Hashimoto's thyroiditis, and knowing that a lot of endocrinologists see primarily diabetes patients? So how do you find somebody with that expertise that our community needs?
Great, thank you. And thanks for the invitation. I think I probably met at the Patient Affairs Committee at the ATA some years ago. So I really appreciate everything you do for the Graves community. Do you want me to repeat the question since I'm holding this? Okay. So how do you find a provider with expertise in Graves' disease or Hashimoto's disease, given that you're an endocrinologist that you might routinely find is going to be, majority probably dealing with diabetes and maybe just a little bit of thyroid issues. And I think it's not an easy question always, and it probably takes a little bit of research. I think the American Thyroid Association has available listings for physicians that you can search by area. And if someone has gone to the trouble to be an active member of the American Thyroid Association, they're probably pretty invested in the care of thyroid disorders. I think that patient organizations, whether you're finding them through websites or even Facebook, can be, very helpful. I think everyone's experience is going to be a little bit different. And so kind of the anecdote of what someone else has found, it may not be totally applicable, but it's certainly a good place to look. And so I think those are good places to start. Speaking from a academic standpoint, many of our clinics are sort of segmented by expertise. So if you were to call USC, for example, and kind of just come into endocrinology and explain what it is that you needed, you'd sort of be triaged to me as a thyroid specialist, as opposed to someone who specializes in diabetes too. So, I think if you are somewhere where you're looking at, practices with, sort of academic specialties, you certainly can kind of make that call and see if you're going to be really pointed to the right direction, if you're able to give, a description of what your condition is.
All right, thank you. So the next question is for Dr. Echalier. do we have any way to predict the course of thyroid eye disease and which patients, for example, I've got some swelling and some eye bulging and some light sensitivity, but I haven't needed any medical or surgical intervention. Do you have a way to identify those patients early that might need surgery or some type of medication down the road? And if you could repeat that question into the mic.
Hello, I'm Dr. Lacey Echalier. Thanks for the question. Thanks for having me. So the question is about predicting severity of thyroid eye disease, how long it's going to last, who's going to need surgery, who is a candidate for medical treatment. And that's fairly complex, but we do have some things that we understand about it. First off, thyroid eye disease is a huge spectrum. There are some people who develop just a little bit of eyelid retraction, some dry eye, all the way up to people who develop compressive optic neuropathy, meaning that it's so severe that it's damaging the nerve that gives them vision, and everything in between. We do expect the course of thyroid eye disease to follow sort of a curve of activity where you have about 18 months of activity, sometimes 6 months to 18 months of really significant progression in activity. I tell patients to expect 18 months to 2 years. We do see people last up to 3 years of active phase. After that, that's followed by sort of a stable phase, sometimes referred to as a quiescent phase, meaning quiet. But the patients are usually at that time left with the majority of the changes they develop through progression, such as the bulging, the eye tightness. If they've developed something called strabismus, where the eyes are not aligned and they have double vision, that tends to persist in the stable phase. There are some ways that people become outliers of this curve that don't stick to the pattern that we expect. Patients that smoke are 7 times more likely to have severe disease, not to burn out, to have blinding disease. And so cigarette smoking, we know as a modifiable risk factor, is the most important thing that patients can do for themselves to avoid having their disease, the progression and the active phase last longer. The other piece is that we know that patients that develop it at an older age tend to have more severe disease. As far as medical and surgical treatments, that's a complex question. I'll start out by saying up until about 2020, we did have some immune modulatory or medicines that you can use to change the antibodies and settle down the immune system to try and treat people's disease. But nothing was really outstanding and consistent. In January of 2020, a medicine called Tepezza or teprotumumab that you might have seen on commercials and all over the place got FDA approval, and that has really changed a lot of what we see as far as medical treatment. And I'll speak a little bit more to that in a little bit. Before that, we really just tried to treat people supportively, and medical treatment is really the mainstay during that active phase. Surgery during the active phase has a very high risk of making disease worse because you're operating on something that's already inflamed and already in a really high level of inflammation and activity. It's also a moving target, and so it's much harder to predict your results. We do try to stay out of surgery until the patient has demonstrated stability for a while, mainly because we can predict better results and it's safer. Surgery is still an option for patients that undergo medical treatment or don't, depending on what symptoms and signs that they're left with. And I always tell my patients, it's as important to me as it is to you. So I base a ton of my treatment on symptoms. If your eyes are scratchy and red, we do, supportive lubrication and things like that, strategies that are simple that you can do at home. There are some patients that are very motivated to treat the proptosis or the bulging or the double vision. And there are lots of conservative things we can do, but sometimes they do progress to surgery anyway. So I think that that's sort of a long-winded response. It's a fairly complex question. I'm happy to take more specific questions about medications or surgeries. And I think there are already some on the list. So I'm going to wrap it up at that point and just say, as far as prediction, we have that sort of model. Smokers, older patients, they tend to have worse disease, and everybody should wait to surgery until they're out of the active phase.
Okay. The next question is for Dr. Ho. So for Graves patients, they have 3 treatment options: radioactive iodine, medications, and surgery. For patients with Hashimoto's, it's typically going to be thyroid replacement hormone, but occasionally they go to surgery. What would the initial consultation look like if a patient comes to you and says, I'm not sure if surgery is right for me? And if you could repeat that question, please.
Sounds good. Once again, I'm Alan Ho. I'm a head and neck surgeon at Cedars in Los Angeles, and I think the question was the if I could rephrase it, it's what are the factors that go into my consultation about whether surgery makes sense in these situations. When a patient comes in with thyroid eye disease or Graves, and I think you also mentioned Hashimoto's, which is an emerging indication for surgery, but not thyroid surgery, but not a absolute indication. I oftentimes take a step back because they've been living with this disease for some time, unlike say like a thyroid nodule patient or a thyroid cancer patient where they had a relatively recent diagnosis. And what I like to try to do is understand what they've done with their endocrinologist or their ophthalmologist, because they probably have had a medium to long-term relationship by that point and have a very fleshed understanding of their condition. Like my colleague here was saying, there's oftentimes many different flavors of Graves or of Hashimoto's, and it may dictate what or determine what I would offer for the patient. But usually if they've gotten to the surgeon's office by this point, it's because they've been recommended to have an operation. In those cases, then I would discuss the reasons underlying why we would want to have surgery and make sure that it synchronizes with what everybody else wishes to do. I would actually also spend time going through the pros and cons of considering radioactive iodine as well. Although I'm not an endocrinologist, I just want to make sure that many times it's not a black and white answer. You can't have radioactive iodine, you need to have surgery, or vice versa. Many times they can still choose. And there are factors that would predict better success, or at least better patient satisfaction if we chose one versus the other. So I think, very obvious reasons why we would consider surgery over something like radioactive iodine is if they have florid, eye disease. I think people feel that the radioactive iodine can exacerbate or worsen those symptoms. I think also patients who are either pregnant or thinking about pregnant in the imminent future, radioactive iodine can throw a real curveball. So the surgery is a little bit more straightforward. So those to me jump out as the two main things why patients come for surgery. Other than that, we would discuss the pros and cons of the operation. I would spend some time discussing that because there are different flavors of Graves and Hashimoto's. We may have a very, I like the word quiescent, a quiet thyroid in which it could be a very straightforward operation, or it could be a very irritated, inflamed, hypervascular thyroid that could lead to a lot of oozing. And in those cases, it might be a longer operation or have a higher chance of complications. And complications, I mean, regarding voice hoarseness from injury to the recurrent laryngeal nerve, or injury to the parathyroid glands, which can cause hypocalcemia. Hypocalcemia, it manifests as tingling or paresthesias in the fingertips or around the mouth. And if it's very severe, patients can be quite miserable. So I just want to make sure people understand those potential consequences before we embark on surgery, even if surgery seems inevitable. I don't want to go too far, or again, it's a very complex question and very far ranging, but those are the initial things I would talk about at a consultation.
So the next question is for Dr. Angell, and I'm going to throw a really hard one at you right at the beginning. This is a question we get all the time. My levels are normal, but I still don't feel well. Now what? How does ThyCa or work with a patient to help them try and get that quality of life back in again?
Right. So we're asking about normal thyroid hormone levels in someone who still has symptoms and doesn't feel well, and how to potentially manage that. I want to say we want to get through all these questions, but you get thyroid people up here and we start wanting to ask each other questions. So I'm restraining myself. This is definitely challenging, and the first thing that I always want to do is make sure that when we say normal, we're really satisfied with someone's levels being ideal, depending on what their complaints are. You hear a lot about being normal, but perhaps being borderline. And even though we don't have strong data that small changes in TSH are generally beneficial, certainly if we can move the range into, say, being relatively high, that might be better. And some people seem to truly know. They come in, they say, I got to be between 1 and 2, and so great. I'm happy to work with people if that's where they need to be, and maybe that's not the experience they've been getting. Once we're there and we're stable, that is when we are currently talking about, hey, what are the alternative treatments that we can try. And I'm going to talk about thyroid hormone replacement for a second. And so this can be the addition of T3 in the amounts that would be normal for the body in people who are hypothyroid. And this has, I think initially was sort of not taken seriously. Now I would say we're in the phase where there's a lot of smoke, but we still don't have the fire. Fire is a good trial that shows, when people are blinded and randomized, that it is very effective. We don't have, but I think we have some strong reasons to think that some people benefit, and not a lot of adverse effects in a general person when you're being careful with it. And so, I'll want to try that. People are aware of it, your natural desiccated preparations, your Armour thyroids and others. This is definitely considered alternative, and something that needs to be used cautiously, but there's no doubt some people have great experiences with it. And so it's an option that's on the table currently. And then I think there are further options that are compounded or other things that I've never seen necessarily be productive. But I think we need to keep an open mind. Now, for people with Graves' disease who are maybe still on an antithyroid drug, methimazole or PTU, I think that can be significantly more challenging. We can still modify the dose to say, let's maybe idealize the levels, but we're also in much less control of what the levels are. We're trying to keep the lid on a boiling pot. If the thyroid is still overactive, Graves' disease can actually fluctuate in its intensity over time. We do kind of have a worsening and improving, but there will be flares. And so, a perfect dose we may find that the condition itself has been a disruption to us. So I think, being attentive to the symptoms, monitoring closely, reassessing and adjusting doses may be important. And maybe we think the levels are normal, but they aren't always.
Thank you. And so the next question is for Dr. Echalier, and I'm actually going to step up and shut the door because we're going to get a little bit of noise from the hallway. It seems like a lot of thyroid eye disease is a waiting game. If you want Tepezza, you wait for the insurance. You mentioned the wait needed for surgical options. And you touched on comfort measures. Can you talk about some of those and what might help patients get through that waiting period?
Sure. So the question is about comfort measures, because there's the waiting period of waiting for the disease to sort of burn out and waiting for insurance approval, basically waiting to get to the point where you get to start looking down the road at ways to feel better and to move past and through the thyroid eye disease. Comfort measures, I think that my top favorite is artificial tears. And for those of you that are asking, you probably have already heard that. Briefly on artificial tears, the stuff that comes in a bottle at the grocery store, if it has preservatives in it, you really shouldn't be using that more than 4 to 6 times a day. If you are using it more frequently than that, the preservatives in it can be irritating to the surface. And so you can kind of start to make yourself feel better and then continue to irritate the eye. Most of those are pretty similar. I don't have any financial disclosures or brand affiliations, but I do think it's worth going through different preservative-free types and finding one that gives you the most comfort. Some people report that one that's very popular doesn't work, but another one does. And so don't give up if you haven't found something that feels good when you put it in. Try other ones, put them in the fridge. Keep them in the fridge, and it's very soothing. Keep them. The other thing I tell my patients is anytime you focus on a visual activity, you subconsciously suppress your blink. So keep artificial tears in your car, in your armchair where you watch TV, or at your computer. Those are, or wherever you do your reading. Those are times when people tend to notice the most irritation and discomfort, and those are opportunities for you to have something right there that's healthy for the ocular surface. It's more than just hydration. It rinses away pollens and particulates and things that, because of the condition, you might be more susceptible to or unable to sweep away effectively because the eyelid changes associated with the disease. At night, some patients with thyroid eye disease can't close their eyes well. And even for those that can, the dryness is just persistent. I like for people to try and use a gel or an ointment in the eyes overnight. You put it in right before you go to sleep because it's going to make you blurry. Genteel gel and Optase gel, I think, are the only gels on the market. I find that, at least that I'm aware of off the cuff, I think men prefer those, and people who do nighttime reading prefer those, or who go up to the bathroom a lot at night, just because they clear faster. They're not as much of an emollient, but I find that patients tolerate the gels a little bit better long term. The ointments, things like Refresh PM, Sustain Nighttime, you can find anything that's basically a petroleum based, and those are very, very protective. Other things you can do, make sure you have a humidifier in your home or in your room. And that all kind of goes into the sort of ocular surface management, hot compresses, drops, humidification of whatever your environment is. Other things to keep you comfortable. It is difficult. Some patients struggle with aching behind the eye, and some of those other symptoms. If it becomes severe, I do treat my patients temporarily with oral steroids if they have a lot of pain and discomfort. And I usually get them on a really robust topical regimen that can include medications like a steroid drop and things like that to try and stabilize the eye before I taper them off of that. It's not something that's going to slow down the proptosis or stop them from developing strabismus or diplopia, but it can help with comfort. Those are the things that first come to mind. It is challenging. Some of my patients have to tape their eyes at night. I have had patients who can't close that I'll apply Botox on the inside of the upper eyelid to the muscle that lifts, that's over tightened by the disease, to allow them to close their eyes more effectively. And so I think, in short, topical lubrication, trying to really just take care of your eyes and keep things with you to keep you comfortable, sunglasses, etc. But then if you're really having a lot of pain and discomfort, you should be evaluated. Oh, the question is to go back through some of the drops that I've found, or my patients have found to be useful. So for the gels, there's Genteel gel, and it's spelled Genteal. You can get it on Amazon or in some stores. Optase is a new brand, and I heard that they have a gel that's pretty nice. For the ointments, there is Sustain, Systane, and it's Sustain Nighttime, Sustain Nighttime, and then there's Refresh PM. And basically you just go to where the contact lens solutions and the eye drops are at your Walgreens or your grocery store, any drugstore, and you will find that there are kind of 3 different levels. So there's your regular artificial tear lubricating drops, and then you've got some that they'll say are more viscous, like gel drops, and then there are some that are proper nighttime gels or ointments to protect the eyes overnight. And since we're on the subject, getting really specific about kind of over-the-counter stuff, be very, I have a lot of patients who come in, they're like, I'm using this Lumify, I'm using this anti-redness drop, my eyes still are bright red and I'm miserable. The drops that are, say, get the redness out, or redness reliever or allergy reliever, have different purposes. And it's important to recognize that, because it can cause rebound redness. It has a lot of medications and preservatives in the drop itself that can cause additional irritation to the ocular surface. And so while I think those are important for photo ops or meetings or family reunions, use your redness reliever, et cetera, I do think that using those regularly, daily, or even multiple times daily, just compounds the irritation of the eye.
The next question is for Dr. Ho, which is how quickly can patients return to work and other activities after surgery? And are there any specific restrictions regarding, lifting or anything like that?
Finally, a straightforward, easy question. I won't be talking everyone's ear off. It's a great question, and I'll be very honest. There are many different philosophies depending on the surgeon. So if you hear different explanations or rationale, no problem. It's just because there really isn't anything established. But I will say my general opinion is that patients will and should be able to eat and talk and walk the first night. They should be able to shower the next morning. And most people will start to feel about 80% normal by day 3, 4, or 5. The most miserable complaint people tend to have is a sore throat, mainly from the anesthesia tube, but also because we're manipulating the neck during the operation. Some people, well, most people will require ibuprofen, Tylenol, and maybe some narcotic for the first night, and afterwards, then over-the-counter pain medicine is just fine. I usually say no heavy lifting or straining or exercise for a week. Many other surgeons will say 2 weeks to be extra safe. But our literature tends to say the reason we do it is we don't want people to strain and pop a blood vessel and get a hematoma and have to come back to surgery. But the highest risk of that happening is within the first 48 hours. I will say other people, I have colleagues who are at, say, places where they get a lot of international patients, like say at Mayo or even where Trevor trained earlier in Boston, and they tell their patients to come in for surgery and then they can fly back the next day. I tend to say no flying for a week. Just the changes in air cabin pressure can affect blood pressure and so on and so forth. So just to tell you that there's a whole range. Some people are very restrictive and conservative. Other people are just a lot more relaxed. I'm somewhere in between. Oh, we have an additional. Okay.
I really do.
Go ahead. He wants to respond.
Yes.
Go ahead.
Yes, please.
So no, I would just wondered if there was any difference between a patient with Graves' disease and maybe a straightforward thyroidectomy of a different kind, someone who is euthyroid, or maybe someone with Graves' disease because of drug intolerance who is hyperthyroid. Do those present any differences in anything you just said?
I would say it's an excellent question. Since now we're going to hone down, I still think the risk of significant meaningful bleeding, which is what I think is a higher incidence for in something like Graves, is very real. I think after 1 week, perhaps the risk is still marginally different. What I would do for a Graves patient, though, for recovery, not for recovery, but for to accommodate for that elevated risk, is probably admit the patient. Some patients we'll let them go home the same day because the risk is more minimal. But for a Graves patient, I almost absolutely will keep them overnight in the house, in-house in the hospital, just to keep a close eye on them in case we do have to return to surgery.
So the next question is for Dr. Angell. Can you talk about the use of antibody testing to diagnose Graves and Hashis, their use through the course of the disease? And the second part of that is, do we have any targeted treatments?
Great. So antibody testing for autoimmune thyroid conditions. So when we're talking about Graves' disease, the most important antibody that we're talking about is the TSH receptor antibody. And if you're looking at lab results or someone is talking about it, they might say TRAB, they might say TSI, they might say TBI. It's a bit of a confusing lexicon, but they're all antibodies that measure something that is to the TSH receptor. This is what causes Graves' disease. This is what causes thyroid eye disease. An antibody that is targeted against the thyroid and stimulates it. So this is a very useful test potentially in diagnosing Graves' disease. right? Because if we measure it, we say, okay, you have some form of Graves' disease, or sometimes I think probably thyroid eye disease in different instances. But it's important to note that people with Graves' disease are often pretty easy to identify. If someone comes and they're hyperthyroid and they have a large goiter and they have thyroid eye disease, this is Graves' disease. This diagnosis can be made clinically. We don't have to have an antibody in order to make the diagnosis. We may monitor the antibodies, so knowing what it is to start with might be useful, but strictly speaking wouldn't be how we know, because we can tell from the presentation. We want to know, is this Graves getting better? Are you headed towards a remission, or are you in remission? And there are pretty good evidence to say that if you get to a point after 12, 18 months and your TSH receptor antibody is no longer detectable, especially if the dose of antithyroid medication is small, that patient is almost certainly in remission. And we can attempt to withdraw medication at that point and see if it's just euthyroid without any need for medication at that point. Whereas if the antibody is still present or hasn't fallen, the thyroid hormone levels might be just fine on the medication. But we think if we take that away, this patient's going to go back to being hyperthyroid because the thing that's causing the condition is still there. So, there's some very good uses for that. For Hashimoto's, generally, we're talking about the TPO antibody. And this is a marker that is generally present in thyroid autoimmune conditions. It's actually present in most patients who have Graves' disease, because Graves' disease is an autoimmune thyroid condition. But certainly people who have Hashimoto's, this is more defining. And so unless we were going to take out the thyroid, look at it under the microscope, see the classic inflammation, TPO antibody is how we really know people have Hashimoto's. It is much less correlated with the thyroid hormone levels, meaning that there are many, many people who have normal thyroid hormone levels and just have the antibodies. Could we say those people have autoimmune thyroid disease of some sort? Yes, but it doesn't seem to be affecting their thyroid function at that time. There's a risk of developing hypothyroidism over time compared to people who don't have antibodies. Antibodies may relate in people who want to become pregnant. There may be some fertility implications to having thyroid autoimmunity as well. So in that sense, I think TPO antibody is a little less well correlated with our management, but it can still be useful in finding the diagnosis for some reasons. Now, do we have targeted treatments for this? I think the short answer is no. In Graves' disease, the antibody does tend to go away with remission. And it seems as though antithyroid drugs themselves, antibody levels go down in comparison to radioactive iodine. With surgery and removal of the thyroid, antibody levels go down because you've taken out the thing, presumably, that the immune system is reacting to. Now, I wouldn't consider those good interventions for the antibody levels that we want to take, but they do have an effect. There are small studies that relate to nutrition, maybe, that influence antibody levels, but I think what's really important, especially for Hashimoto's and TPO, is that there are not data that show that influences the thyroid hormone levels, that people with hypothyroidism stop being hypothyroid or have changes in dose, even if antibody levels may fluctuate. The immunology of autoimmune thyroid conditions is something that I think is still being studied at UCLA. A lot of interest and investigation, I know right now. So there may be applications in the future. There's actually something hopeful there from the scientific world.
Thank you. Dr. Echalier, so you touched on surgery and the fact that we need to wait until the disease is in its inactive phase. So once a patient finally gets to that inactive phase, what are the surgical options and how do you stage those?
So the question is about surgical options after making it to the quiescent phase of thyroid eye disease. I think I want to piggyback briefly on something that Dr. Angell said about the antibody levels in Graves' disease, such as TSI, TRAb, TBII, et cetera. In those cases, I have patients ask me about that. Not everybody does this. It is very practitioner dependent. As far as I understand, I prefer to get a baseline level of those, as he said, not really to monitor those, but once I approach that point where I believe that the patient is clinically in the quiet phase, I like to revisit those levels and see if they've come down. It's useful and it's helpful in reassuring me that surgery is appropriate at that time. As far as surgical options, there are three main categories. So proptosis is where the eyes bulge. Strabismus is where the eyes deviate and they're not lined up. They're kind of looking different ways. And lid retraction and ptosis are terms for if the eyelids are too tight or too low, getting in the way of the vision. Lagophthalmos is a term for if the eyelids are too tight to close. And eyelid surgery takes multiple different forms. For proptosis specifically, orbital decompression is a surgery where you remove 1 to 4 walls of the eye socket or fat. You can do this in conjunction with one another or alone. And it depends on your goals for how much you want to reduce the bulging of the eyes. This surgery is done in a hospital setting. Some patients will have one eye done at a time. Some surgeons prefer to do both. That's my preference. And based on the patient's symptoms and how severe their proptosis is, you might do what's called a balanced decompression, which is where you take kind of the inner and the outer wall. The reason this is called balanced is because you have the lowest risk afterward of having double vision after surgery. For really severe cases, you're sort of you need to take out a little bit more, create bigger space. I think of orbital decompression is like enlarging a room at your home, right? So you can knock out a wall to make a room bigger. And that's basically what orbital decompression is. And so you have some patients will get the top wall, the roof, as we say, removed. The most typical is inner and outer wall, and then in severe cases to have what we call the floor or the lower wall taken out. Taking out fat adds a little bit of reduction of the bulging, but it's not as effective as taking out the bony walls or reducing them in size. Onto strabismus surgery. That's basically usually a one and done sort of surgery where you have a strabismus surgeon who tries to align the eyes by loosening, tightening, or rearranging the muscles that are attached to the eye surface. This should be done after orbital decompression. If you're going to do orbital decompression, that's kind of the first one to go to. If you don't need that and you have strabismus, then that's the first one. After all of these things, and if you don't need either of the first two, eyelid surgery is indicated. There's specific reasons for doing it in this sort of time frame, and it has to do with predictability of results. There are some surgeons that feel like you can reasonably combine some of these. And it's on a patient-dependent basis, but typically you've got your orbital decompression, you've got strabismus surgery, and then eyelid malposition surgery, meaning the eyelid is not working the way it's supposed to, it's not positioned the way it needs to be to protect the ocular surface. Then that is the most common surgery that we do. I always tell patients, a lot of people hate the way that it looks, but their eyes are comfortable or safe. And I try to remind them that this isn't really about appearances or cosmetics. It's about trying to get people as close as possible to what I consider their pre-morbid state, meaning how their eyes felt and looked and were before they developed thyroid eye disease.
And actually, just to add on to that point, that can be an issue for insurance companies too. They might say, oh, this is, cosmetic surgery. You're going for your 20-year high school reunion and you want to look good. Can you touch on that a little bit?
Yeah, the concept of what insurance will pay for as far as eyelid surgery is always kind of a sticking point. Decompression and strabismus surgery, you don't have much difficulty getting those things covered. Eyelid surgery, for the most part, there are some specific indications that almost all patients with moderate to severe thyroid eye disease have, where their eye is overly dry, that it's red, that they have what we call conjunctival injection and things like that. As long as you document those things, most patients are candidates to have sort of tightening or relaxing so that the opening, we call it the palpebral fissure, but basically the opening between the lids is at a more normal size. And that I find is pretty, it's a relatively reasonable, you know how insurance companies are. But as far as insurance companies go, I haven't had a lot of difficulty getting those things covered. There is a lot of swelling and puffiness in the lower and upper eyelids that bothers patients and is really apparent and makes them look sick or super swollen, and that bothers patients as well. That's a little harder to address. You can often find ways to address it in the upper eyelids in conjunction with the other types of eyelid correction we discussed. The lower eyelids are a little harder because the puffiness there is also something that is a well-known cosmetic surgery called a lower blepharoplasty. So it's a little patient dependent. As far as making sure that the ocular surface is comfortable and protected, insurance is pretty good about covering. When it comes to kind of lower eyelid puffiness or even upper eyelid puffiness without ocular signs or symptoms, it's harder.
Okay. The next question is for Dr. Ho, and you actually touched on this earlier, but we had a question about low calcium levels after thyroid surgery.
All right, the question is about low calcium levels or hypoparathyroidism / hypocalcemia after surgery. It's a complication that surgeons hate to see. It's a known complication, and there's always going to be a small percentage of cases, even in the best of hands, where you will have hypoparathyroidism. I would say the literature would say that patients with Graves and Hashimoto's likely have a modestly to moderately higher chance of having hypoparathyroidism, mainly because the bed in which the parathyroids sit is a hostile environment, right? Patients with Graves or Hashimoto's, as was mentioned earlier, can be somewhat inflamed. It's the nidus by which the basis of Graves and Hashimoto's is formed. So the home in which the parathyroids sit is not in a very favorable location. The other thing about parathyroids is that they can be very finicky, they can be very sensitive, they can be fragile, and then the same can be said about their blood supply. The blood supply to them can be very finicky, fragile, different from patient to patient, and very sometimes difficult to extricate even in the best of hands. So I think that would kind of first be something I would spend a lot of time talking about if we have that situation. In order to minimize those chances, I think for Graves in particular, we oftentimes will put patients on lugal iodine 2 or 3 weeks before surgery. That is, it's very old-fashioned, I would say, right? It's very old-fashioned. I actually thought it was voodoo, and I wasn't doing it at first. And then I saw that it still is in our very modern guidelines, and a lot of people do it. It doesn't hurt. It's actually somewhat difficult to find these days. A lot of pharmacies don't carry it. A lot of over-the-counter online sites carry it, but not at the particular dose that is considered medically necessary. So, but most of the time, if you have it, what it does essentially is it is supposed to minimize oozing and bleeding during the operation. And it's really the bleeding that can sometimes occlude or make it very difficult to find these parathyroid glands. If you have a drier or less oozy sort of surgical bed, then the parathyroids will be much easier to find and preserve. So other than that, finding the parathyroids, doing very meticulous surgery around them, those are the optimal opportunities in order to preserve and prevent hypoparathyroidism. Do you want me to speak about treating it and
Yes, please.
Oh, sure. So what we do is right at the end of surgery, we actually check a parathyroid level. We don't check calcium because calcium takes a couple days in order to, or a day or two in order to manifest. but parathyroid hormone changes very, very quickly. If we find that it's low, then we'll start patients on calcium and an activated vitamin D medication called calcitriol right away. We find that if you start them right in the recovery room, the patients are much less likely to become symptomatic. If you wait and you wait till the next day or that evening, sometimes when you fall behind, it's much harder to catch up. I don't actually know the pathophysiology or mechanism behind that. Maybe Trevor does, but we find that patients are much happier if you catch them ahead of time. Then we modulate that medication. Patients, we follow them the next day or two, make sure that they don't develop florid symptoms, like very severe symptoms, so we don't have to adjust. And then we oftentimes will recheck the parathyroid level probably about a week later to make sure that everything's okay. By then, things have sort of normalized. If the parathyroid level is still low, we still find that patients can come down on the doses. And generally speaking, if there is hypoparathyroidism, in our hands, usually it's transient and it only lasts somewhere anywhere between a few weeks to maybe a few months. But usually, typically, it recovers and we can wean patients off of those medications.
All right, we'll do one more lightning round and then open it up to the floor and anybody that has joined us online. For Dr. Angell, can you talk about long-term use of anti-thyroid drugs? I know when I first got diagnosed, there was the idea that, oh, you gave patients methimazole for 2 years and then you yanked it away, and if they went hyperthyroid again, it was surgery or RII. Has that thinking evolved?
Yeah, so long-term use of antithyroid medications for people with Graves' hyperthyroidism. So historically in the United States, you would show up with Graves and just get radioactive iodine, even maybe before you were diagnosed. And then it was very common to have people on antithyroid medication for the first 1 to 2 years. And if there was no remission, then definitely you needed radioactive iodine at that point. The data that have come from other parts of the world, Japan largely, and the experience from Iran as well. And people on antithyroid drugs for many, many years doing just fine. And so that is in part what has opened the door to this. But in the United States, we've seen use of radioactive iodine decline and antithyroid drugs surpass it for Graves' disease, no question. And so, someone who's not gone into remission after a year or two and stays on antithyroid medication. So number one, that person may still go into remission. It might take longer. The remission rate that we find later on after 5 years, 6 years, there are still more people who will eventually get there. And two, what about the person who may never remit? Some people will be on low doses, and that might be something like 5 milligrams of methimazole. The disease is present, but is not very active. And we feel like those people can continue to be followed and do well on continued methimazole. If someone is well controlled, not in remission, but is needing a high dose, that might mean that the condition's very active. We're doing a pretty good job, again, of keeping that lid on the boiling pot, but we might be more concerned that, hey, should something happen, we're immediately going to go back to a significant degree of hyperthyroidism. So that might worry us more. And so if someone has complications from being hyperthyroid, that might be irregular heart rhythms like atrial fibrillation, or the symptoms they experience when they become hyperthyroid are very serious. That might be someone who we would think more carefully about, keeping them on it long term. On the other side, if someone is not a good candidate or is for other interventions, there are other health conditions, make surgery, less favorable, their thyroid eye disease makes radioactive iodine less favorable, then we're probably going to be more inclined to see if they can stay on long-term medication as well. It compared to being hypothyroid and being on levothyroxine in general, being on methimazole probably requires more monitoring. And there's more chance of not being stable compared to many patients who are on levothyroxine. And if that were to be interrupted briefly, would have very little change in their hormone levels or symptoms and doesn't have to be checked frequently. That's not the experience for everybody, I realize, but if we were speaking generally about sort of the pros and cons, that might be a factor that we are paying attention to. Talking about international patients or someone who may be harder to monitor than other people, it may favor a definitive therapy and not staying on long-term medication as well. So I think as these two have said, also, there's always a kind of a depends and a nuance to how the decision gets made. But I think everyone should think that it is a viable possibility at this point.
Dr. Echalier, you mentioned Tepezza. Do you have patients that have done that, and what's the response been? And there are a number of new medications in clinical trials. Is there one in particular that you are keeping an eye on?
So the question is about Tepezza, my patients' experiences with Tepezza, and about other similar medications in the pipeline. So I've been treating patients with Tepezza since February of 2020 because that's when it was approved. It really has changed. And I have no, I have no financial disclosures, no conflict of interest, but I have seen Tepezza reduce the amount of surgeries that patients require overall. In general, it's pretty well tolerated. I feel like there's a little bit of a fear factor because it was sort of rushed to approval, and it does have side effects like everything else. But in general, I found that overall the response rate is high, and it's doing things that we really just didn't have a medication that could do prior, which is part of the reason why it got, I believe it got orphan drug designation at its first approval. The side effects that we worry about, the most common is myalgias, or basically being achy after your infusions. Some patients will have a little bit of hair loss. That's pretty uncommon. I've only had one or two, and it's only been on the arms. Getting into things that are, well, and you can expect some patients will have a little bit of stomach upset. That's less common. The two more significant things that we worry about is women of childbearing age really need to be on birth control while they're on Tepezza and for 6 months after. That's kind of a hard stop. You really want those patients to be in a position where they don't, where they're not trying to get pregnant during or directly after Tepezza. We have seen some amenorrhea, meaning loss of periods, at least temporarily, in patients on Tepezza, which is another concern for younger women that are wanting to have a family. And in those cases, we just kind of counsel them. And again, if the disease is not that severe, a lot of times we can just follow them supportively. But if the disease is severe, that's often something that people are motivated to try because the rate of that problem is low. And we're seeing that it does eventually return. Even if their periods become irregular or absent for a period of time, we're seeing recovery, if slow in some patients. And the final piece, and this is kind of the sticking point as far as the most severe side effect that we've seen, and that is hearing loss. We have seen hearing loss that in most cases returns, but there have been some patients with permanent hearing loss. Current guidelines and in my practice, I have my patients get a baseline audiogram. I have them get an audiogram in the middle of their infusions and then at the end as well. I've had a handful of patients who have had hearing loss, and all of them have recovered. Some of it has been associated with weight loss, causing eustachian tube dysfunction and some other things, or they've just had tinnitus or ringing in their ears that's gone away. But it's something you really want to watch for and definitely get some baseline testing for. Overall, my experience with Tepezza has been pretty positive, even for my patients that have had the more severe side effects. I do try to tell patients, since we've been talking about insurance and other options and things, at this time, it is a little tricky. It's a bit of just being persistent to get people approved, but most patients you can get approved through their insurance with the help of the company that makes it through different programs, if they don't have good coverage. It is kind of at this point, there are some patients that can get a second run of Tepezza, but that's a lot harder to get approved if you can get it approved at all. And I think it's worth saying that for my patients that are smokers, I try to really encourage them to take that risk factor off of our plate. So our first run with Tepezza is hopefully the only one we have to do. It is 8 infusions, and that's another thing that patients find a little bit intimidating, is that it's not a pill. It is an infusion every 3 weeks for 8 infusions. It's about 6 months of commitment. Okay. So I think that those are the things that's worth knowing about Tepezza. Overall though, in my practice, my patients have had in general really good benefit from trying this medicine if they're a good candidate. There are several drugs now that are being in similar classes or following the similar pathways that are being tested. And some of them are not infusions. Some of them are subcutaneous. And those are the ones that I look the most forward to seeing the results of. If there's something that comes up in the future, hopefully in the next couple of years, that is not an infusion but has similar efficacy, I would be very excited to offer that to my patients. And then sort of the final piece of that is there is one drug that I'm aware of that's in early clinical trial stages that they're hoping to see both systemic Graves response as well as thyroid eye disease response. And that's sort of the golden egg. Would be ideal to find a medication that could treat both simultaneously. And we don't have that quite yet, but there are some that are that look hopeful. So.
Well, we're bumping up against the end of our time. I've got one last question for Dr. Ho. Again, if you're here live and you didn't get your question answered, our info is in the back there. Please take a card and we'll try to get an answer for you. If you are online and we're not able to get your question answered, our email and our website should be in the chat. So please reach out and we'll try to get your question covered. So last question for Dr. Ho. Can patients with Graves and Hashis have these so-called scarless surgery procedures done?
Great question.
Question at the very end.
No, we'll keep it brief. The question was, can Graves and Hashimoto's patients undergo transoral scarless or other remote access type surgeries? The main operations that have been bandied about are through the axilla or through the armpit, and then through the mouth, going in front of the teeth but behind the lips. And the short answer is no. These are highly specialized operations for highly selected patients, mainly patients with very, very calm, small nodules where there's not a lot of possibility for need to open the patient for an open operation. So they're very, very selected cases, and because there's a higher chance of oozing during the operation, that the scarless techniques can't really address sufficiently. I think most people have veered away from doing, virtually everybody has veered away from doing these sorts of approaches for Graves and Hashimoto's.
All right, thank you. All right, thank you so much to our panelists, Dr. Angell, Dr. Ho, Dr. Echalier. We really thank you for volunteering your time to be here today. And I think that is a wrap. Thanks very much.